students, welcome back to this Deliberations in Obs and Gynae MCQs. We are now going to discuss the NEET 2022 questions which came today, and I've got most of the recalls, and I hope most of the choices are also correct, but then there'll always be some discussions and always some suggestions from all of you. You're most welcome to get back to me on the PrepLadder forum or also on my personal email. Let me just start by saying that all of you went through a lot for preparing for these exams, and some of you wanted this postponed, but then it eventually happened, and I think it's for the good that all of you will settle earlier than later, and I wish you all the luck for the results. So we'll start with the first MCQ, guys. Which of the following is the correct calorie requirement in the 12 weeks pregnant woman? Now, in pregnancy, the calorie requirement increases, but please remember, in the first trimester, we don't have to increase the calories. If I tell you the values from Williams Obstetrics, so the first trimester, no calorie increase. In the second trimester, 350 per day, and in the third trimester, 450 kilocalories per day is the increase requirement. So, if we see in these choices, the one which is coming closest is the choice B, 400 in the third trimester, because Williams gives around 450, so 400 is a good answer here. 400 in the third trimester, 400 in the first trimester is wrong, 300 in the first trimester is wrong, 300 in all trimesters is wrong. So when we say the calorie requirement of any human, it's around 25 to 30 kilocalories per kg per day, and when a person is a diabetic, then we reduce it to 20 to 25 kilocalories per day, depending on whether he's well controlled, that is around 25 kilocalories, or it's not well controlled, so 20 kilocalories. But if a person is pregnant, then it is around 35 to 40 kilocalories per kg per day. So in that 35 to 40 kilocalories per kg per day, carbohydrates constitute the 50% and proteins is 30% of the calorie requirement, and fats is around 20%. So that's about this MCQ. Let's move on to the next one. Identify the type of hymen here. Now, when we see the hymen, we all know that a hymen is an opening which will have a nice, circular membrane around the vaginal opening. But then sometimes it is imperforate, sometimes it is having a shape like this. So when a shape like this is there, we say it is a hymen which is septate. Now this is septate hymen, and then that's the MCQ here. Then sometimes it might be imperforate, which that when there's an imperforate hymen, a person will be having accumulation of menstrual blood. When she's around 13, 14, she'll start menstruating, and the blood will accumulate in the uterus and in the vagina, but it'll never be able to come out. That's what is known as a cryptomenorrhea, you know that. And she'll have periodic pain, that she's feeling that she's having pain for 3-4 days every month, but no menstruation happens. So that is what is a cryptomenorrhea, hidden menstruation. Can present with imperforate hymen, can also present with transverse vaginal septum. Now, when you say the hymen shape, it can also, if you see the vaginal opening, the normal hymen shape would be something like this. There'll be a thin membrane around the vaginal opening like this. This is the normal hymen opening. Probably I made it a little large here, but this is the normal opening. But now sometimes it could be just an annular opening, just a small annular opening like this, or it could be another choice which was given here. There will be multiple small openings, multiple small perforations, like we call it a cribriform hymen. So this last one was the cribriform hymen, this one. So like the ethmoid plate in ENT you read, isn't it? That's a cribriform plate. So this is also having small perforations, the hymen sometimes, like a cribriform hymen. Okay, so I think not much about there to discuss about the hymen here. This is a separate hymen in the one which we have discussed just now. All right, let's move on and see another question. Identify the histocybergraphy image given below. Now, I don't know what were the choices and what was the image, but we just, try to recollect from the students who have given us the information. And, this question has come many times, and they'll give an HSG, but let me tell you from the beginning that whenever there's a question given like this, try to think in terms of separate uterus, because it is far more common than a bicornate. But yes, they can give you a bicornate uterus in the discussion. So yes, in the beginning itself, I'm trying to tell you that separate uterus is far more common than a bicornate uterus, and separate uterus is indeed the most common Mullerian defect. All right. So when we say, when we look at this picture here, you have to see that the angle which is between these two cavities if you suspend like this, you can see it's an acute angle here. So if the angle is acute, if it is less than 75 degrees, it goes in favor of a septate uterus. And if it was more than 105, you know, actually we have to just say acute and obtuse. That itself is enough. But yes, nowadays you people are becoming perfectionists and you should know the exact angle. So yes, if it is less than 75 degrees, it is more in the favor of septate, and if it is more than 105, it's an obtuse angle, and that is more in favor of a biconate uterus. Like the one which is given here, this is looking like a septate uterus to me, and but yes, this could be biconate also, because there could be you know, straight fundus, but that is seen only on a laparoscopy. So what we say, that we can, rather than doing this, we can see the intercornual distance. This intercornual distance, if it is more than 4 centimeters, then it is favoring a biconate uterus, and if it is less than 4 centimeters, it is again favoring a septate uterus. So yes, there are many other calculations which keep coming into our discussions, but in this one, the you know, the exact size of the picture given in your exam won't be, you know, you won't be able to measure the scale, whether it is 4 centimeters, more than 4 or less than 4. That's why the calculations cannot be done so accurately. So that's why I think the only way and the only reasonable method of diagnosing whether it's a septate or a biconate is to see the angle, and between these two cavities it's an acute angle. So I will go with a septate uterus in this one, and not a biconate uterus, definitely not a diadelphys. You know, a diadelphys looks something like this. It's a 2 uterus, and it'll be like this. You will see it nicely in the histocybergraphy. It could be 1 vagina or 2 vagina. You know, this is unicollis, or if the 2 openings like this, then we call it a bicollis. So diadelphys could be unicollis or bicollis. Of course, a unicornate uterus would look something like this. Yes, it looks something like this. So yes, that is a unicorn uterus with a rudimentary horn. This rudimentary horn could be, you know, communicating or non-communicating. Many details are there to this, but for the time being, we'll say that this is a septate uterus, and let's move on to another question. So after 5 days of a normal vaginal delivery, a woman was brought to the casualty at 11 p.m. by her husband with a history of crying, that the woman was crying, loss of appetite, difficulty in sleeping, and feeling of low self-esteem. Her general physical examination is unremarkable. There are no worrisome findings from pelvic examination. Which of the following best describes the symptoms of postpartum? So psychiatric disorders of women in pregnancy, especially of the postpartum period, there could be so many, but the 3 most common ones which we know are the blues and the psychosis and depression. Now, the ones which are even more commoner are the blues. So postpartum blues is the most common type of psychiatric disorder which is seen in pregnant women, especially in the postnatal time, and it is seen in almost 50 to 80% of women. Yes, 50 to 80% women have this blues, and around 1% women or lesser will have psychosis, and depression is around 10 to 15% of women. So yes, the most common type of psychiatric disorder in postpartum period are the blues, and there's a biochemical reason for the blues to happen, and that is the progesterone withdrawal. So progesterone withdrawal, the high progesterone which is present, that is suddenly withdrawn because of a pregnancy has now delivered. So progesterone withdrawal is the biochemical reason for the blues to happen, and it is the most common psychiatric disorder. Now another thing, I've told you the blues, psychosis, depression, BPD, that's the order in which they come. Don't think that is going to come, you know, all the 3 disorders are going to come in that order, you know. I'm trying to say that blues happen in the early part of the postpartum period, and psychosis happen a little bit later, and depression is the last to come. I'm not saying a woman has to go through all these 3. Please don't misunderstand. So blues, they happen, I'm so sorry. Blues happen in the first 1 week, and psychosis happens roughly in the first 1 month, and depression happens in the roughly in the first 1 year. I mean, roughly, if you want to remember. So 1 month to 3 months also it can be. I can write the range 1 to 3 months, and one which is around 6 months to 1 year, if you really want to go into the precise. Of course, psychosis and depression are totally psychiatric domain, and I'm sure they can make you understand these things much better than I can. But remember, depression requires maybe a lot of personal care and a lot of counseling, and psychosis may even require admission. I'm sure the psychiatric, the person who is the faculty who is taking care of the subject is going to explain these things extremely nicely to you. So we'll go to the next question. A primary gravidae is brought home by her relatives just within 1 hour of a vaginal delivery of a full-term healthy infant. The baby is doing well. Very strange kind of a question. I mean, I don't think anybody would bring a patient back within 1 hour of a delivery from the hospital. I think she must have delivered in the village, health center or something like that, or maybe in a dai's home. I don't think this kind of, discharge is there in any kind of an hospital in the country. Even in a small hospital in the village won't do that. At least for a day they will keep, or at least for 6 hours they'll keep. Never mind. So let's move on and say they're saying it's the patient has come back home within 1 hour of the delivery. On examination, the patient is hypotensive, hypoxic, and has disseminated intravascular coagulation. I don't know how they diagnose that, but this is the information which I was given. So if there's hypotension and there's DIC, then there has to be a coagulation defect, and that the only choice which is coming close to any of all of these symptoms put together is obviously amniotic fluid embolism. But amniotic fluid embolism, there's not much time left for discussion. The patient would have been dead by the time they diagnosed this in the house. So yes, I'm sure the history was different and the question was much different, but there was a question on amniotic fluid embolism. Please remember, the mortality with amniotic fluid embolism more than 50%, and it is actually the most common cause of death in the West, because they don't have women dying because of PPH so much. We have PPH deaths so many in our country, and the maternal mortality rate, it is, yes, now it is 103. It is reducing, but it is still not less than 100. We would want it to be less than 70. But most deaths in our country are because of obstetric hemorrhage, and in obstetric hemorrhage, the most common hemorrhage is the postpartum hemorrhage. But in the West, the most common cause of women dying after delivery is thromboembolism, and amniotic fluid embolism is another cause. So embolic disorders are the ones which are the cause of women dying after delivery. So I'm sure that vaginal bleeding is not the cause of this happening. Albuminuria, I don't know how this was a choice. And if there was a rupture uterus, it could be also, leading to this. But since the history is of a primary gravida, I don't think that primary gravidas not generally rupture the uterus. A second or a third gravida, multi-gravida generally rupture the uterus. A primary gravida rupturing a uterus is not likely, because if there is an obstruction, then the uterus goes into inertia. But if a woman is a multi-gravida, then the contraction will go on happening even if there's an obstruction and there's a large baby, the uterus will go on contracting the multi-gravida. So those are the ones which a thinner uterus, they can have more ruptures. So the history is not much in favor of a ruptured uterus and abdominal distension, and the DIC is favoring the diagnosis of amniotic fluid embolism. So I'll go with this answer. All right, there's another question. Identify the area marked in green in this pelvis. Now, I think the question was something to do with the area of the mid-pelvis, so that's why we've given you a picture like this. So the area marked in the pelvis is from the back of the pubic symphysis to the lowest part of the pubic symphysis. So this is the zone of the mid-pelvis, no doubt about that. So let us see a little bit more about this. I think they must be trying to ask you the plane, the greatest plane of pelvic dimensions and the plane of least pelvic dimensions. I think they've been trying to ask you that. Maybe the choices are a little different. So I'll just tell you what is the plane of mid cavity, also known as the plane of the greatest pelvic dimensions. It is the plane of greatest pelvic dimension. It starts from the mid part of the pubic symphysis. Now this is the pubic symphysis, the mid part is here. It starts from here, and from here it goes to the junction of the second and the third. See, second and the third sacral vertebra. So it goes from here till here, and then laterally it goes to the acetabulum and the superior part of the greater sciatic notch. So that is the plane of the greatest pelvic dimensions. Now, what is the plane where it's the least pelvic dimensions? So plane of least pelvic dimensions, it is from the lowest part of the pubic symphysis, and it goes to the tip of the sacrum here. It goes to the tip of the sacrum. So the part of the pelvis which is of obstetric importance. Obviously, the baby has to go through the plane of least pelvic dimensions to come out. From the greatest pelvic dimensions, even a bigger baby would come. So, baby has to go through the least pelvic dimensions to come out eventually. So, that's why we say it is the obstetric plane, the plane of least pelvic dimensions. So, it is from the lower part of the pubic symphysis to the tip of the sacrum posteriorly and laterally the ischial spines. You also know that the ischial spines, the bispinous diameter, is the narrowest part of the mid pelvis. So if the baby goes through the ischial spines, we know this baby is going to deliver. So that's why we always tell you this, that if the the biparallel diameter, which is 9.5, goes through the bispinous diameter, which is 10.5. So bispinous diameter is the one of the dimensions of the least pelvic dimensions, one of the diameters of the least pelvic dimensions. And if the head goes through this part, then we know the delivery is going to happen. So which part of the head are we going to discuss? The broadest part of the head. When the broadest part of the head, which is the biparallel diameter, 9.5, goes to the narrowest part of the mid pelvis, which is the bispinous diameter, then the chances of delivery is much more likely to happen. It's actually very good. So what is that station when we know that this has happened? I'll repeat. When the broadest part of the head, biparallel diameter, has gone through the narrowest part of the pelvis, which is bispinous diameter, then the station of the head is +2. So +2 station and below is the place where, when you do a PV and you feel the vertex at +2 and below, the delivery is going to happen. All right, so that's why forceps in vacuum is also +2 and below. Very interesting chapter. You must spend some time reading this, and you can go through the app, and I'm sure you'll understand. It's a wonderful way to understand basic obstetrics, that when the head is at +2 and below, the chance of delivery is much more. Okay, 34-year-old female, previous cesarean section of the classical type, is now having breech presentation confirmed on ultrasound at 34 weeks and insists on a normal vaginal delivery. What will you do? Now, previous classical cesarean, all of you are very well aware that when we see the uterus, the lower segment and the upper segment, all of you know very well that this lower segment will not contract. It retracts and the upper segment contracts. So yes, when I do a lower segment cesarean section like this, next time I can give a trial of normal vaginal delivery. Why? Because the lower segment, if a woman had a LSCS for the first pregnancy, next time if you want to give a trial of normal vaginal delivery, you know that the lower segment is only going to retract, the upper segment is going to contract. So the place where you given the incision, the lower segment, it's not going to take part in a contraction, it's going to take part in a retraction. So it's the passive, the lower segment is a passive part. So that's why a lower segment cesarean section can be given a trial of normal vaginal delivery in the next pregnancy. But since the incision is in the upper segment, this is the incision which you've given to deliver a baby, and now next time, this is the part of the uterus which is going to contract. So the chance of upper segment rupturing in the next delivery is more than 10%. So upper segment can rupture in labor more than 10%, and the lower segment is 0.5% to 1%. Some people say 0.5 to 2% also. Maybe I would have said it somewhere 2%, but then 0.5 to 1% to 2% is the limit where a lower segment can rupture. Of course, you have to do a obstetric assessment. The head should be not big for the pelvis, and the pelvis should be adequate. There should not be any CPD to give a trial of normal vaginal delivery. There's a previous lower segment cesarean. So no CPD, you can give a trial. But in a classical cesarean, even if it's a perfect pelvis and the baby's head is small and the baby's average weight is only 2.3 kgs and the pelvis is big, please don't give a trial of normal vaginal delivery. So that's as simple as that. Now, coming to this question. A 34-year-old patient with a previous classical cesarean has also a breech presentation. So there's no way that you're going to give a trial. Classical cesarean, do a cesarean next time. Previous LSCS, let me write that for you. Previous LSCS plus a breech now. This also cesarean section. Even this I will not give a trial because breach with any other obstetric event becomes a complicated breach. So if there's a complicated breach, I'm not going to give a trial of normal vaginal delivery as it is. So please understand, breach with the previous LACS, breach with the classical CS, anyway we're not going to give a trial of normal vaginal delivery. Okay, that's about this question. So answer is plan a cesarean at 37 weeks. End of discussion. Now, please, I've kept this slide plain for you to just say, if there's a primary breach, or there's a woman who's had a normal delivery, no cesarean, and next time she's a multigravida with a breach, please don't say cesarean section. Primary breach, a second gravida with a normal previous delivery, now breach, both of these will deliver in an institutional setup under the care of an experienced obstetrician. So please don't say that breach requires cesarean section. I know a lot of institutes say primary breach, do a cesarean. That is because nobody is going to willing to take chances these days, and people are a little scared of obstetrics. I know that. So now doctors are scared of women when they're dealing with breach, because we know that breach has a slightly more chance of injuries. Breech vaginal delivery has slightly more chance of injuries, and also hypoxic brain damage. So these kind of things do happen in breech, but they can be limited if you do this delivery in an institute under the care of an experienced obstetrician. But no obstetrician is now willing to take a chance to do a normal vaginal delivery in a breech. But that is what is in practice. If you go by the book, and that's the MCQ which is going to come, and you people who have given the final year MBBS exam in India, all of you, at least some of you would have been asked about breech vaginal delivery. Please, all of you read about the Pinard's maneuver and the Lovset's maneuver and the aftercoming head and maneuvers for that. Why do we teach you all this? So that you're going to just do a cesarean when you become obstetricians? Please, we teach you breech because we do breech vaginal delivery. So don't say primary breech is equal to cesarean, and don't say that is a multigravida who's got a normal vaginal delivery this time. That is even better case for doing a breech vaginal delivery. Okay, so in an institution setup under the care of a good obstetrician, you can do a breech vaginal delivery. Okay, so that question we've discussed already. I've given you the information, but I have to tell you that breech will deliver normally. Okay, a primary gravida presented with a soft tender abdomen. I think they're trying to suggest abruption. Never mind. On examination, the fetus is in right occipital-posterior presentation. How will you deliver? So the most common position of vertex is left occipital transverse or left occipital anterior. What is the most common malposition of vertex? Occipital posterior towards the right. So this is the most common malposition of vertex. Of course, vertex is the most common presenting part, and the most common presentation, most common is LOT, LOA, and most common malposition is ROP. So, occipital-posterior delivers. Now, that malposition, you please read about this. This is the one which will come in the exam. They're also asking you how occipital-posterior rotates to occipital-anterior, what types of pelvis it can rotate. Yes, it can rotate in a gynecoid, it can rotate in a android partly, but in an anthropoid it will not rotate. So you must read about occipital-posterior. It will deliver either as occipital-anterior, or it will stay occipital-posterior and deliver. So please remember, how will you deliver? I'll do a normal vaginal delivery. So occipital-posterior, 80% turns to occipital-anterior, and delivery is possible, and 15 to 16 stays occipital-posterior, and this also delivers, but by phase 2 pubis delivery. All of you know that if the head is towards the sacrum, then the face will be towards the symphysis pubis. So phase 2 pubis, occipital-posterior delivers phase 2 pubis. Phase 2 pubis is not in phase presenting part. Phase 2 pubis is in persistent occipital-posterior. So yes, if it can turn to occipital-anterior, it is mostly seen in the gynecoid. If it stays occipital-posterior, it's in the anthropoid. Now, around 2 to 4% rotates to occipital-transverse, and yes, partly rotates to occipital-transverse. You can complete, as an obstetrician, you can hold the head and complete the rotation. So rotates to occipital-transverse, and remaining rotation by manual rotation followed by forceps extraction. Now that is in a android pelvis, right? All of this has been discussed, and I'm sure all of you know that AIMS exams used to ask this question so many times, that what is the method of delivery in a case of occipital posterior if it presents early in labor? And they used to be very fond of this answer, wait and watch, because a woman with occipital posterior baby will eventually deliver. Okay. Yes, there's another variation, that if it is the occipital transverse which is neglected and the head is stuck there for a long time, the head is having a lot of molding, and there is a dry labor because the liquor has already gone off, and there is a lot of cap put, then we know it's in deep transverse arrest. So yes, occipital transverse you can manually rotate, but if it is neglected there for a long time, what we call as the deep transverse arrest. So if they ask you deep transverse arrest, I think there's another question based on that. If it's a deep transverse arrest, go ahead and do a cesarean section. So another question, the following procedure is being done on a 25-year-old lady in labor. While doing this procedure, you know, there's one hand on the abdomen, which is, there's an arrow which is showing you pushing the hand upwards, another hand is on the cord, the arrow is showing that you're pulling it down. So this arrow and this arrow, please note. So this is what is a control cord traction. With one hand you're pulling the umbilical cord, gently tugging on it, you're not yanking it off, okay, you're just gently tugging on it. With the other hand you're giving a counter traction on the uterus. So control cord traction. So this is also known as the Brandt-Andrews technique. So Brandt-Andrews technique, also known as controlled cord traction, is the method of doing a placental delivery. There's no doubt about that. All right. So while doing this, the umbilical cord gets torn. What should be the best thing to do? Now, I think the question in the exam was very clear, but what has been recalled to me is looking a little vague. You know what I would do if the cord snaps? It happens so many times. You know, whenever you are in the labor room and you've done suppose 7-8 deliveries, 2 or 3 cords will snap when you're doing. So when they snap, what do? We don't do MRP. We don't do manual removal for all of them. We just increase the oxytocin, the placenta comes out. But yes, the best thing to do would be a manual removal of placenta. So it depends on what kind of question was asked in the exam, guys. If you ask me here, I will answer manual removal of the placenta under general anesthesia. But if the language was, what is the next thing to do? You know, sometimes these questions really irritate you when they're recalled, because what comes in the exam is very clear. I'm sure those who are listening to this, because tomorrow or day after you'll be there on the YouTube and you'll be discussing with each other. Those who have written the exam, the question would have been very clear. So exam question is very clear. What is recalled by you and what is put by us into the guidebooks, that becomes very confusing. So yes, what I would do if a placenta is being delivered and the cord snaps, I'll increase the oxytocin drip and I'll give a gentle halka sa massage on the abdomen and the placenta will deliver. If it doesn't come out, then I'll do MRP. But here they've asked the best thing to do. I mean, if this was the question, I'll go with manual removal of the placenta. All right, let's move on. Uterine artery Doppler done at 14 weeks detects which of the following? Now the choices, I don't know, I didn't get all of them. So, you know, uterine artery Doppler, all of you know that if you're trying to do the Doppler and there's a systolic flow and a diastolic flow, and systolic is always more than the diastolic. But yes, the earliest sign is that there could be a notching. So there's a diastolic notching. It's the earliest sign of fetal compromise, the first sign of fetal compromise. So uterine artery Doppler done at 14 weeks detects which of the following? They've not given a sign. They've just said it detects what. So you can get back to me what was given in the exam. But then for the time being, if there's a diastolic notching, which is generally the finding which is given to us by a lot of radiologists, that when we are doing an ultrasound at 14 weeks or 18 weeks, it is showing us uterine artery notching of the bilateral uterine arteries. So it makes me a little worried that maybe later there could be a early onset preeclamptic toxemia or simply hypertension of pregnancy. So yes, around 14 weeks it is telling me that yes, around 20-24 weeks there might be hypertension. So early onset eclampsia seems like a reasonable choice to this MCQ. I'm sure the choices and the language was a little different, but whatever it is, for the time being, I'll go with early onset preeclampsia. Of course, this can also, if there's a preeclampsia, this can also predict intrauterine growth restriction. Let's go to the next question. A 25-year-old lady with history of 2 weeks of amenorrhea came in the emergency department with complaints of scanty vaginal bleeding On examination, no adnexal mass was noted. In lab investigations, HCG was 1400 milli-international units per ml. On ultrasound, uterus was bulky, trilamina endometrium was seen. Patient's vitals were stable. What is the next step to do? Now, there's a lot of history which is given here in this MCQ, but I'm very sure that you understand that a woman is pregnant who's not had periods for 2 weeks. Now she's come with spotting. The first thing I'll think is of a threatened abortion. Okay, yes, and I'll do an ultrasound and see. When I do an ultrasound, a transvaginal sonography, will show me a sac within 4.5 weeks. So I do a TVS always. So when I do a TVS, the uterus is on the mouth of the cervix or in the fornix of the vagina. So if it is the baby is in the uterus, then I will see with the TVS. Or if the baby is in the fallopian tube, like this, then again I'll see with the transvaginal sonography. But yes, if it is not seen, then what happens? Like in this MCQ, that the uterus is bulky, but on ultrasound, a trilaminar endometrium was seen. Now, when a trilaminar endometrium is seen, that's a normal uterine lining in the uterus. If you see, the endometrium grows from both the sides like this. It grows and it grows from this side. So it gives a pattern like this. It gives a pattern like this. So this is the one layer, second layer, and the third layer. It gives a trilaminar. So empty uterus, which is good for implantation, is what is known as a trilaminar endometrium. Immediately around the time of ovulation onwards, you'll see this trilaminar endometrium. So when you see this and there's no sac, then what is the problem in this MCQ? That the patient is pregnant, you cannot localize a sac. Sometimes the fetus is just too small to be seen by a transvaginal sonography also, because we know the TVS is a good equipment to see a uterine or an extrauterine tubal pregnancy. Now you cannot see even with the TVS, it could be very small. Now how can we justify? Look at the values. The value is only 1400. Now why I say 1400? Now that is what is the fundamental of, that is what is the fundamental of discriminatory zone of HCG levels. So what is the discriminatory zone? Now discriminatory zone of HCG level is, if the HCG level is more than 1500, you see sac by transvaginal sonography. And if it is more than 6500, you see sac by transabdominal sonography. So discriminatory zone of HCG is more than these values, you can see a sac. So if it is more than 1500, you can see a sac by transvaginal sonography. Since the value is only 1400 and you've not seen on transvaginal sonography also, it's all right. It's a too small a pregnancy to be picked up by a TVS, whether it's in the uterus or in the fallopian tube. So no problem. Now you can observe the patient for some time, and what else you can do? You can look for doubling titers. Doubling titer is also another way to help the diagnosis. Doubling of HCG will take place in 48 hours, then it's a normal uterine pregnancy. If it takes in 5 to 7 days, then it is a ectopic pregnancy. So the doubling of HCG levels also gives you an indication whether the pregnancy is in the tube or in the uterus. So that's what you're going to do in this patient, because you've not seen a sac, she's pregnant, she's having some spotting. It could be threatened abortion, uterine pregnancy, or it could be a tubal pregnancy. It can be either of these. So if it doubles in 2 days, let's say it's 1400 now, and in 2 days it becomes 2800, it's a normal intrauterine pregnancy. And if it doesn't double, then it can be suggesting a ectopic pregnancy. So best answer to this one is a repeat HCG after 48 hours. All right, let's go to the next question. Now, what is the position of the uterus on postpartum day 2? Now that's a question which has, I don't know whether they really asked you a question like this, because it's a little, person to person variation kind of a finding, and no book really gives, the uterus is here and how it comes down 2 fingers or 4 fingers like that. It's just a person to person kind of an assessment. I doubt whether these were the choices, but if these were the choices, let me try and help you. See, we always ask you this question definitely, that the uterus is somewhere here when it's a normal uterus in the pelvis, and immediately after delivery, where is the uterus? Now that's a favorite MCQ in the exams. Why? it is at or below the level of umbilicus. That you should know. She's delivered just now, and when you feel the uterus, it is at or below the level of the umbilicus. What is the meaning of this? That uterus will now slowly go reducing in size and get into the pelvis and become normal. So it becomes a normal organ in how many weeks? A normal organ in 4 to 6 weeks. It will come into the pelvis in 2 weeks. Today when she is delivered, it's at the level of the umbilicus. Tomorrow, I can make an incision. I can feel the feet. I can feel the uterus through the abdomen, and I can make an incision on that place of the abdomen, get into the abdomen, and ligate both the tubes easily. A tubectomy is very easy when a patient has just delivered. So tomorrow or day after, the uterus will still be in the abdomen. I can do an easy puerperal sterilization or a postpartum sterilization. That's the clinical significance of uterus being inside the abdomen. And we cannot do it beyond 2 weeks because the uterus becomes a pelvic organ. So around 7 to 10 days is the time by which you can finish a puerperal sterilization. Best is today, she delivers, tomorrow or day after you should do it. Best is that. Upper limit is 7 to 10 days. Now, another significance of this uterine size reducing, that the rate of reducing or involution, like we call it, is around 1.5 to 2 centimeters per day. So the uterus should come down roughly 2 centimeters per day, or 2 fingers, like they're trying to say. So today she's delivered, tomorrow it'll be 2 fingers below the umbilicus, day after it'll be 4 fingers below the umbilicus, because every day it reduces by roughly 2 centimeters. So I'm trying to derive while I'm trying to explain you, because this is what is not a very good question and not a very good kind of choices. But yes, 2 fingers below the umbilicus on the first day and 4 fingers below the umbilicus on the second day. That's the derivation I've tried to do in front of you. And also you must remember what is the most common cause of subinvolution. The uterus is not going back to the pelvis the way I'm trying to tell you. It's taking time. Subinvolution, infections, retained bits, and fibroids. Okay, subinvolution is infection, retained bits, and fibroids. Okay, let's move on. On which site of implantation will cause severe vaginal bleeding and no sign of rupture ectopic despite being 22 weeks of gestation? So they're trying to ask you a question where that there's a pregnancy which is outside the uterus, and although there might be a vaginal bleeding because of the embryo dying and shedding of the endometrium, that's the cause of vaginal bleeding in an ectopic, but there's no signs of rupture of an ectopic. So what kind of ectopic will not rupture? Obviously, all ectopics which are in the tube will eventually rupture, or if it is in the abdomen, there it will not rupture. Now that is what is the MCQ here, because if it is in the tube, the time of rupture for the ischemic ectopic, ischemic is the first to rupture. It's not the most common. The most common ectopic is ampullary. First to rupture is the ischemic, and the time of rupture is 4 to 6 weeks. And ampullary ectopic, the time to rupture is 6 to 8 weeks. And the cornual ectopic, also known as the interstitial, this one will rupture around 12 to 16 weeks, the last to rupture. So interstitium or the cornu is the same, and it's in the uterine muscle. The cornu is here, it's in the area of the uterine muscle here. This is the cornu here, this is the cornu, this is the cornu. So this pregnancy will grow for a while before it ruptures. So that's the last to rupture. But now if the pregnancy is in the abdomen, it will never rupture, isn't it? It may stop growing, but it doesn't rupture. So the abdominal ectopic, even 22 weeks, it won't rupture. Now please, there is a question often asked, which ectopic pregnancy can go till term? First of all, rarely it can go to term. and the most likely, I mean, of all the ectopics, the only one which can very, very rarely go till term is the abdominal ectopic, okay? And only one case of ovarian ectopic has been reported to go till term, and around 6-7 years it was reported, or 8-9 years back, it was in Australia. There was a pregnancy in the ovary which went up to term, but even in Australia it was a Indian woman which had this kind of a presentation. So yes, it is very rare to have an ovarian, and please remember that's only one case in the history of science which has been reported, ovarian ectopic till term. Otherwise, very rarely abdominal ectopics can go till term. Okay. Now, here onwards I've got some questions which are mostly just a couple of lines which have been recalled. So I'll try to explain, and you can always suggest to me on the forum if the question was incomplete, and I'm sure you can correlate with what I'm trying to discuss here. The fetus is at the level of the ischial spine. It is right occipital transverse, molding ++, caput ++. What do you mean by molding? Molding is that the head, the scalp bones, the head bones, the bones of the head, when they come close, it is molding. When they touch each other, it is molding, and when they overlap also, it is worst type of molding. So overlapping of the scalp bones is known as the worst type of molding. So when the bones of the baby is having that kind of molding and there is too much of a caput, that means this baby has tried his best to accommodate and go through the pelvis, but it's not going through. It is obviously a baby which is not going to deliver. So what you should do a cesarean section. This is what we had discussed when we were discussing occipital posterior earlier in the discussions. Occipital posterior, if it is occipital transverse, you are the obstetrician in the labor room, you see occipital transverse, you can rotate it. You can rotate it manually and deliver it. Manual rotation, forceps extraction for occipital transverse. But when it is a neglected occipital transverse like this, there's a molding, there's a caput, and the liquor is probably drained off, please don't do any stunts. Do a cesarean section, because this is a deep transverse arrest, right occipital posterior, which has now become a deep transverse arrest, and this management is a cesarean section and nothing else. All right, so deep transverse arrest, please don't try to do any stunts, do a cesarean section. Now another one-liner, a preeclampsia patient presented with absent bilateral plantar reflex, I mean same patellar reflex absent, again they've written what is the possible diagnosis. So I think they're trying to say a patient who had preeclampsia is now thrown in eclampsia and is now having absent knee jerks. So a patient who is about to throw a convulsion or is convulsing will have exaggerated knee jerks. If it is reduced, probably the patient had thrown a fit and max self was started. So yeah, it comes back to, forget this question, comes back to reading magnesium sulfate administration and magnesium sulfate toxicity. Please read Pritchard's regime only. Pritchard regime, all the other regimes like the Zuspan and the Leans regime and the Menin's cocktail and the Lytic cocktail and whatever other regimes, Sibai regime, there's so many regimes which have been taught to us, and most of them I've also forgotten. They will never ask you in the exams, because the only regime which is given in most of the hospitals still, and for the last 20-25 years, magnesium sulfate has been accepted. So please read this one properly. And magnesium sulfate, the dosage, how to give, how to monitor, please know this nicely. So when you want to give max self after delivery, give it for 24 hours. This came also in your INI-CET. Give it for 24 hours after the delivery, and you should monitor the knee jerks, respiratory rate, and urinary output. All of these are satisfactory, then give the next dose of magnesium sulfate. So this patient is probably having magnesium sulfate toxicity. So what are the therapeutic levels? So therapeutic levels of max self, or all of you know, are 4 to 7 milliequivalents per liter. And first sign of toxicity is when it is more than 8 to 10, and that is knee jerk suppression. First sign of toxicity. Of course, if it is 10 to 12, there is respiratory depression, more than 15, respiratory arrest, more than 25, cardiac arrest. All right. Of course, the antidote for magnesium sulfate is calcium gluconate. All right, let's move on and see next question. What is the absolute contraindication of doing a cervical cerclage? Now, cerclage is done for a short cervix. All of you know that. If the cervix is like this, if it is very short, then it will open earlier than term. So you have to put a stitch here. Most common cerclage is the McDonald cerclage. It is applied after 12 weeks. We apply it, and after 37 completed weeks, we will remove it. That is what is the basic. Now, when you're doing a cervical cerclage, please remember that you will put it when the patient is a little before the second trimester, because cervical shortness can cause a second trimester abortion or a third trimester early delivery, which is known as a preterm delivery. So before 28, if it cervix opens and delivers, it is a abortion. After 28 weeks, when the baby is viable, we call it a preterm labor. So a short cervix can cause abortion, can cause preterm labor. So when should you put a cerclage? Generally around after 12 weeks to around 20 weeks you should put it. You can put it till 28 weeks because that's the time of viability. You can put it till 28 weeks, but the best time is around 12 weeks to 20 weeks generally. Now, when you're putting a cerclage, the patient cannot be leaking. If the bag of membranes is ruptured, then there's no chance of the pregnancy going. If the bag of membrane ruptures at second trimester, 14 weeks, 20 weeks, the liquor is going off, severe oligohydramnios will happen, the baby will have no chance, Potter's triad will happen. Potter's triad, all of oligoamnios causing severe pulmonary hyperplasia and restriction anomalies and flattening of the faces of the baby because of no liquor. So please, liquor draining off, don't even think of continuing the pregnancy, definitely not putting a cerclage. So rupture membranes is the answer to this one. Bag of water in the vagina. Now that's a little difficult MCQ for people who are writing PG entrance, because it's a little difficult for my PGs to understand this. So bag of membranes in the vagina, try to understand this, that the fetus is here in the uterus and there's a bag of membrane here which is bulging into the vagina. It is not probably ruptured, okay? This is the like a bag which is coming out. So what happens, sometimes when a patient presents to us like this, I know the cervix has opened more than around 4 centimeters or 5 centimeters it is. I know that it is not yet ruptured. Ruptured, you cannot put a cerclage. But sometimes when the bag is coming out like this, I can do a stunt. Yes, these are called stunts. What I can do, I can put a gauze piece here which is held by a sponge holder like this. And I press this, with this gauze piece, I press this bag inside the vagina. Inside the cervix like this. I press it back into the cervix. And then I put in a stitch here like that. So yes, I can do this, and it is known as a rescue cerclage. The patient has now gone into the time when she's about to push the baby out and the bag is in the vagina. It's not a contraindication to do the cerclage. It's a tough cerclage to do. Experienced people can still do around 3 to 4 centimeters, 5 centimeters. I've done it quite a few times. But yes, it is not always that you have success with this thin cervix and the cervix is having the bag of membrane coming out. So you push this membrane back, stitch the cervix on it, and hope that she doesn't deliver. I had a few cases which have actually gone till term with them, but then it's a postgraduate topic. I don't know why they asked you a choice like this. Of course, the other two choices are not worth discussing. Okay, definitely rupture of membranes is the answer to this MCQ. So, pregnant lady at 32 weeks of gestation developed proteinuria, hypertension. Doctors suspect a case of placental insufficiency. What is it due to? All right. So when we discuss this, remember they're trying to ask you what is the cause of hypertension of pregnancy. Please remember there's just one line which I want you to remember. Pregnancy-induced hypertension, if you know the chapter, just remember it as placenta-induced hypertension. Placenta is the cause of hypertension. So placenta starts maturing at 20 weeks. If that doesn't happen, PH happens. So after 20 weeks, remember I say after 20 weeks if the BP is high, it is PH, because after 20 weeks the placenta did not form properly in this woman. So what is the main etiology? We say the placental vessels did not form properly and the perfusion to the baby is not good. There is vasospasm in the placental vasculature. If there is vasospasm, perfusion to the baby is less. Mother increases her blood pressure to open the vasospasm. So the baby gets perfusion at the cost of mother increasing her blood pressure. So the main etiology is vasospasm. So placenta-induced hypertension. Why? Because there is vasospasm in the placenta. So what do we do here? We make the patient go as close as possible to term and deliver. Moment the delivery happens and the placenta goes out, the blood pressure comes back to normal within 1 week in 90%. That's also an MCQ. When does the blood pressure comes back to normal in a hypertensive patient after delivery? 90% patients within 1 week. The most definitive management of an eclampsia is delivery of the baby. Of course, drug of choice is Maxwell, but the most definitive management is the delivery of the baby. All right. So if you remember that, then you'll remember it is better than remembering as pregnancy-induced hypertension. Remember it as placenta-induced hypertension. All right. So let us try and understand by this famous picture of Williams obstetrics that what happens in a normal pregnancy and what is happening in a PIH pregnancy. So in a normal pregnancy, what happens that the blood vessels, see this blood vessel here, this blood vessels here, they are losing the smooth muscle here, the tunica intima. The smooth muscles here are replaced by trophoblastic invasion. So the since cytotrophoblasts and the cytotrophoblasts are there in the villi. Now, apart from the villi, they are extravillous trophoblastic cells. So the extravillous trophoblastic cells will come and they will come and replace the smooth muscle layer. So the extravillous trophoblast, see here, this extravillous trophoblast has come and replaced the smooth muscle layer. So when the smooth muscle layer goes off, the blood vessels will stay dilated and give a good perfusion to the fetus. Now, in eclampsia, can you see? Look at this blood vessel here. This does not have this extravillous trophoblast coming here. So see this, can you see this? All this muscle is persisting. So persistence of smooth muscle layer causes vasospasm. That's why perfusion is not very good in the placenta, mother increase the blood pressure. So what is this? Extravillous trophoblast has not come to the endovascular area. The endovascular extravillous trophoblast has not invaded and replaced the smooth muscle layer. So these are not very complicated terms. We know that since cytotrophoblast and cytotrophoblast are the trophoblastic cells in the villi. Apart from the villi, extravillous trophoblast will come and replace the smooth muscle layer. Now this extravillous trophoblast is not there, so there is persistence of the smooth muscle causing vasospasm. So that's what is written here. The extravillous cytotrophoblast invasion in the spiral artery. All right, so I think we'll just say choice number A is the best answer here. Okay, choice number A is the best answer here. Extravillous cytotrophoblast invasion in the spiral artery is deficient. So whatever is the language of the question, don't get into the nitty-gritty. What is the cause of vasospasm in PIH or preeclamptic toxemia? It is the extravillous trophoblast invasion which is deficient in the spiral arteries. If you remember that, more than enough information. I would want you to remember that it is placenta-induced hypertension. You remove the placenta and the patient is fine. That is, remove the baby, take out the placenta, and the blood pressure comes back to normal. So yes, the most definitive management of eclampsia is termination of pregnancy. All right. So those are the questions which I got for recall in this MCQ exam for NEET 22. And if you have more questions and you feel that some of them were not discussed, then you can always get back to me on the PrepLadder forum or on my email, which is Dr.Prassan@yahoo.com. All right. So best luck with the results. So do write back to me at this email if you have any more queries, and wish you all the best with the results. Bye-bye.